So these areas are the primary areas where we have to start, and we are working, and we strengthen. Then we can gradually scale it up. And now only there are 2 slides, and I think there are 4 domains where there should be some thought, or there should be some thing we have to do for the betterment of our future in telemedicine. So we don't have Telemedicine Act, so it might be needed. The revision of guideline is needed because there are several flaws. There is a guideline which had been made during the COVID, so we have to revise it. And the documents are made, they are not the static, they are dynamic, so it can be changed. So we need the SOP for telemedicine, and there should be one high level regulatory committee in ministry or by the government where it can regulate all those sort of providers and all those sort of applications or services, and technical support team. We should not forget this. And regarding financing, as we all know, it should be linked with social health security program. There are several social health security programs. So the financing is the very key critical issue. So it should be assured. There will be the user fee for secondary and tertiary care, which is not covered by the health insurance as well. There should be some costing done. Telemedicine service, the services should be listed. What services can we provide through telemedicine? Yeah, we know, we have seen that telesurgery is also done. So all those things. We are what there are certain institutions which are working with teleophthalmoscopy, otoscopy. They are being done. Consultation is done. We cannot do palpation, but we can hear the breath sound or cardiac sound through the devices. So it is so advanced. So there should be listing of all those services what should be provided through telemedicine, and they should be costed. And the program support should be through government. It might be in the regular annual work plan of Ministry of Health and Population. It might be from Science and Technology, Telecom, the program for this, and provinces and hospital itself should have some sort of programs regarding the financing as well. So the third, it might come first or it might be kept last. It is up to you, but the political commitment should be there. And I will say we are weak on advocating these with our political leaders, I already said, with intersectoral ministries as well, and 3-tier of governments. We have said, but we had not been successful for this. So the political commitment and the strategy for universal health coverage should be advocated, and there should be resource generation should be done for telemedicine as well program. So political commitment is in third, and the last, we can say we should integrate telemedicine with our EHR. Health record system, there should be incorporated. The implementation guidelines should be based on WHO. There are some benchmark or some exemplary guidelines which guide us to run the activities of the program. So WHO guideline and technical trainings to implementers as well. And I have listed the last point about awareness and advocacy among the technocrats. It's a very difficult term, technocrats, I'm sorry. Because I cannot convince, or I already said, we cannot convince the decision maker or policy makers. They might be bureaucrats. So what digital health actually is, what telemedicine actually is. Only having this screen, somebody is talking in front of you in a video conferencing, it might not be telemedicine service. There might be some sort of other architecture for that. So it's very difficult to convince our co-workers, our seniors, our juniors regarding telemedicine. So I have put this, sorry for that. So this is my last slide to you. There have been huge changes in the government. You can see when 2000, it is 2001, I think, how we started this telemedicine, and how we are. So there has been a huge changes. We have achieved a lot, but there are miles to go. There are huge room of improvements to be done. And we are here, we can work together, and the changes can be made. Thank you very much. Thank you for listening me. And this is the last presentation from WHO. Our national professional officers from WHO, Mr. Pawan Kumar Gimire, will be highlighting the WHO guidance and efforts for telemedicine implementation. Thank you.
Thank you, Chair. So I feel myself privileged to be here for this much awaited event that we were looking for from last several years, to have all the champions together in the telemedicine. So this is very good opportunity for us as well to talk on the telemedicine. This looks like the previous presentations, the planning, how to plan the telemedicine. So Ranji shared several steps. Dr. Madan also shared some government plans. This should be done by the government. So in the same direction, I'm presenting the WHO, how WHO have recommended and suggested the steps for telemedicine in member countries. So while we talk of the telemedicine, we have to take care of the use and accommodation of the ICT, information and communication technology, in the health system. So when we started the digital health, we have taken this as the very cost-effective approach for reaching to people and bringing the health service provider and recipients together. So it will obviously reduce the time, cost, and geographic barriers, and also help support to reduce the barriers and minimize the barriers. So telemedicine also taken as within the broader umbrella of digital health, and this is basically the barrier of geography and barrier of human resource shortage and other kind of things and specialties. WHO have defined this telemedicine in the same line as this is where the distance is the critical factor, the telemedicine use of ICT for bringing people and health service together. And also reaching the unreached and having universal health coverage to accelerate on this, and also the STG, the telemedicine is also adopted as very much good tool for having the USC. So within this framework, WHO is promoting the telemedicine as well. And this COVID have also provoked all of us to have the telemedicine, because at that time we had a limitation in the mobility, limitation in the physical presence and interaction for the health services. So when we talk about the WHO chronology, basically it was WHO have thought all these in 2005, but when the e-health strategy came out, then in 2013 we started talking on the external and interoperability. Then in this way, in 2020 we found this consolidated telemedicine implementation guide for the member countries. The 2020, so why so late? I think this is because the COVID situation have encouraged, and also there was very big demand of telemedicine during those periods. So WHO was pressurized to provide some guidance on this telemedicine. Though came late, that's good. This guide suggests the telemedicine plans to have to complete in 3 phases. So first phase is the situational assessment, then plan the implementation, then monitoring, evaluation, and have continuous improvement. So we have to follow these 3 phases, phase-wise approach for having this complete the telemedicine implementation programs. This guideline does not talk in the nitty-gritty and how to design what software to use, how to make the processes, but it simply suggests we have to have a SOP, we have to have governance. So things are there. So this is the broad outline of the plan. So let us see how our plan fits with this one. So first, in this part of situational assessment, it is suggested to have first build the team and establish the goal. So we are several times we are talking, having some steering committee, technical working groups, support teams. So everything comes here to have the very good team to initiate with the telemedicine programs and establish the goal, how to reach the people to whom we are going to reach, how many people and services will our coverage of the telemedicine. So setting the goal and scope of the program that should be done before while situation analysis. Then also we have to have some health program context and target. Which health program we include in our telemedicine services, and what should be the context for that one? Whether we are also taking care of emergency services, or only we talk of the basic health services, or primary care, or some kind of services of mental health. So let us define the health program and the context and targets as well. The third step suggested is to do the landscape analysis, what is going on in the country. WHO guidance have suggested to scratch and start from the beginning. That suggests to do some landscape analysis, know the situation, what we have now, and start from there, what we have now. So in Nepal also, we have several telemedicine projects. So we don't go for making the foundation and going on that. Just we start from there where we are. So for that, we need to have some kind of landscape analysis of telemedicine in Nepal. So this is also planned. This is also planned by Ministry of Health. And assess the enabling environment. So this is the one of the enabling environment. We have lots of people together. Yesterday we had, so there are societies, agencies. We have external development partners who are supporting, and the policy environment is there. We have some laws to initiate with the telemedicine and to have some strong telemedicine system. So, we have to analyze the enabling environment of what we have in the country, and also the education and digital literacy that is very going strong in Nepal. That may be also one of this enabling environment. So in the second phase, we go for planning for implementation. So in this context, we have to analyze how our telemedicine system will operate. We don't imitate or make copies of other systems, but we have to develop our own and define our system, how our telemedicine will operate, which technology we use, how to use. So this all comes in this step. And then we talk of the safety of the patient, and also the professional safety of the service providers. So this is not happen. This is not happen. We don't have any document that says the degree of safety to the patient, and there is no personal safety guarantee of the services providing through the telemedicine. So there should be. And then establish standard operating procedure for several things. Like while we talk of the telemedicine, there are two components, tele and medicine. So SOP is needed for both tele and medicine. So we should have combined SOP for several things, not only one SOP work for all. We may have SOP by services, we may have SOP for technical arrangements. So it serves to have establish some standard operating procedures. Then we should have client patient engagement, and we should be aware of that. After having these telemedicine services, whether we are going to limit the access of the people or we are going to increase the access of the people. Sometimes the technology that limit the access to services, that is happening in some places, in some systems. When we launch some digital technologies and system, the people who cannot use that one, they are marginalized. So we have to take care in mind that whether our system will increase and promote the equity, or that limits the equity, that kind of thing. We have to think, and human rights and other conditions have to be taken care of before, and we also have to consider all this. For that, we need client patient engagement and have their opinion be collected before planning the telemedicine. Then budgeting should be done in the implementation phase. That is a very critical factor. How much cost we have to the project incur, and in the long run, what support we need, from where we are getting the funds, and how to make how we can generate the revenue for the sustained telemedicine programs. So that is one of the tips suggested in the this guide. So lastly, there should be some monitoring evaluation framework for that one. With some indicators are suggested how our telemedicine program goes ahead, and how we monitor, how to set up the monitoring and oversight mechanism, and then how we measure the goal, progress towards the goal. So this is all about the implementation, how we are going on. Then lastly, there are some presumed and anticipated risk of having telemedicine, and issues are there. Then we have to have plan how to mitigate them. So I'll show a few of the presumed risk, and then the issues in the telemedicine, the guideline have suggested. First, in the leadership and governance, a lack of governance mechanism and regulatory, that may be the one of the first issue that should be done by establishing a team and having a structure for this one. Then we should have a strategy and investment in this domain. The insufficient resource may be a risk. After having a telemedicine project 1 or 2 years, then we may not have fund for maintenance, and then that collapse. So sufficient resource. For this one, it shows that we have to embed the telemedicine in the health system, not as a project differently in the isolation, but the health system that should have telemedicine in their organogram, their system, their process, and structure. Telemedicine should not be done on the as per OIS. That should be part of the health system. So it suggests, if we have a telemedicine in the system, our system organogram and our whole of the service package, then it will sustain, and the budgetary issues will be solved for the long run. Then there is another issue: how we do reimburse for the services. The health service providers are providing the services. There is no any mechanism to reimburse them. So we have to have this one. Then we may not have a lack of telemedicine regulation. Then legal liability across jurisdiction is one of the factors. Nowadays, we hear that some hospitals in Nepal, they are having communication with Apollo Hospital and other Delhi or Bangkok or Singapore. But we have to check whether that is regulatory or not, whether that can be done or not. If we contact any of the hospital in Nepal, they contact the hospital in Bangkok, the law of the Bangkok applies to that. Thailand government law is applied to that. That is their services. So crossing this legal jurisdiction, we have to have some kind of communication and some engagement with them to have this one. Data protection and privacy is always the issue in the telemedicine as well. Patient, they should be ensured of their data privacy and their data protection kind of thing. Then infrastructure, whether our services is accessible by all, in the sense of universal health coverage, that should not limit any people for getting the services. So this comes here, and we have to take care of this one. And for this, we have to have different modalities for different kind of people. For the disabled, for other kind of people, how our telemedicine services we design. So we have to take into consideration different condition of the people. Then workforce, the major factor here, the change management, the resistance from the health worker that may come. Obviously, with the traditionally working health workers, they may not accept easily the telemedicine. So for that, from designing the telemedicine program, it is suggested to engage them, the health worker themselves, and and find their comfortability, their acceptability to the telemedicine programs. Then there may be some low-level engagement, like we plan for 1 week, all daily telemedicine services, but the health workers, they may not uptake that services, and they cannot run. They do not run. They may not wish to run. So it should be taken care in advance. Then quality of care and medical liability. What the quality of care we ensure with the telemedicine services, and what with the medical liability to the health professional they are providing the services. So there are some mitigation measures that is supporting with the training, and then services where quality is not compromised with the telemedicine services. If you go for complex services, then there may be some issues over there. So start from where we don't have to have compromise with the quality. We can have some clear guidance on the quality control. Then risk of privacy and security breach prevention is there. So we have to mitigate some of the application. If we use some inferior kind of software and some network and some kind of applications, then we may have this kind of problem in the future. So we have to use some robust software from some valid sources, the very good digital health products to use in the telemedicine services, so that this kind of privacy and security breach kind of things will be protected. Then last, the fragmentation of the digital health landscape we are having here. We are having fragmented approaches. To be aware of that, and for that some standard and interoperability would be set by regulating agency to have all the systems together, and we should not say these are fragmented. So these are the presumed risk in the telemedicine services. We may have many contextual, but these are the common issues found in the telemedicine services. So this is the last, I'm talking of how we started some digital health kind of thing. In 1958, we started telephone reporting from the field officer for malaria reporting. Then gradually in 2005, 13, and 2018, we have WHO World Health Assembly resolution on digital health. So in 2020, 2022, we have now the digital health guidance from the WHO, and in 2020, we have a global digital health strategy. So all these things are going on. There are maybe some intervention missing, but these are the broad I have listed. So first telemedicine, I have here said 2004, but Ryan was saying 2001. So this is because we don't know each other's intervention. This is happening. So in future, I think after following this guidance and having going with Dr. Madan's plan, and as suggested by Rajendra, we'll have very good telemedicine plan for Nepal, and that will sustain for years. Thank you very much. Thank you.
Thank you all. Sorry, I would like to interrupt. So because we are running out of time, actually I had requested many of you to be present. So maybe we'll have informal discussion after we close the formal session. And we have got very young and energetic leader in ministry. And in his leadership, our digital health will grow, and we are all here to help you, to be with you. This declaration we'll be sharing through email or other services, and you can add your comments or suggestions in this. And Arun sir also has provided me this digital Nepal framework for health. This also I will be sharing with you all, and we can have discussion continued. With this, I would like to request Dr. Moriyama for the closing remarks, and then we'll have informal discussion. Yes, Dr. Subhas. Because of the time, I think after closing, we'll open the floor maybe, because we have many questions. I know that, but Dr. Madan also has already cleared so many things. So yeah. Thank you.
All right.
Okay, thank you for joining our 16th Asian Telemedicine Symposium with us. Surely maybe through these 2 days intense time, we're able to share our knowledge and experience in telemedicine. Before the pandemic, our telemedicine is mainly focusing on doctor education to share the knowledge just between the doctors or nurses or something like that. But this time you were able to watch the various attempts, challenging achievement of telemedicine, mainly focusing on doctor to patient or doctor to patient with nurse, right? So this is a dramatical changes through the pandemic. Something was happened in recent few years. Unfortunately, something was a pandemic. But anyway, through in some countries, the telemedicine is becoming more advancing, and now they can be one of the leading country of telemedicine field, maybe. So including us, Japan, we'd like to learn from a lot from those countries. And I'd like to talk a little bit about the Nepalese situation. So I sincerely appreciate the Dr. Udaya to have this kind of good opportunity to get together. Maybe this is the first time opportunity to get together from medical sector and governmental sector and company sector. Something has just happened here, right? This is maybe the start of the telemedicine in Nepal. And through the discussion in 2 days, I learned and I realized the enthusiasm of doctors and the social contribution of companies and some issues to be solved from the government, maybe. But I believe you can solve this problem and go forward to the telemedicine. And then I believe you will be able to one of the advanced country in telemedicine because you have very strong needs of telemedicine. That's why I believe you can be the leader in this field in the near future. So thank you again for joining us for 2 days. This Asian Telemedicine Symposium is actually an annual event. Next, we will organize this symposium in the end of this year or early next year. Detail is not confirmed, but we surely said which we will hold this symposium somewhere in the world, right? Okay, so but I hope to meet you again in the next ATS and hope to hear the proceeding of telemedicine in Nepal. Okay, thank you again and see you again. Thank you.
Thank you. Now informal session will start, and maybe some of our seniors are busy because of the APAN, they have some program, so they can leave. Okay, Dr. Subhas wants.
मेरो 2-3 point. First point regarding the resolution. हिजो एउटा important कुरा आएको थियो कि for the sustainable development of telemedicine, the program has to be incorporated in National Health Insurance Plan and other insurance plans. Only then it works prolonged. Srishti addressed that point, and that should be incorporated. One point. One query to WHO represented, not representative. Okay, Pawan sir. What is the support plan from WHO in technology and funding regarding the development of telemedicine? That didn't come. You only mentioned budgeting is required. So many expect those things from WHO, so we need the answer. And third point, Rajendra sarko bhanaima alikati mero healthy comments ke cha bhandakheri regarding wahako e-health ko development ko kura gardakheri we should not forget few names: Midas, Dafe, Mediflow, Dolphin, Hamro Doctor, and many more. And the first health mobile app in Nepal is Hospitals Nepal. Because मैले तपाईलाई भनेको आमाको मायाको पटक पटक कुरा आयो, with due respect to आमाको माया, but you should, as an advisor, you should maintain those unbiased presentation. That's my input, if I'm not wrong. Okay, thank you. Ask Foundation, I know.
Yeah. So that is why Telemedicine Society is there. So we will include all of you.
Thank you. Yeah, this was also a question I was looking for, how WHO support. So basically WHO don't have such big fund for investing in the projects. There are some policies. No, that is not the case. That depends on the context. WHO policy is that for the fragile health settings, we don't have in Nepal such settings. So in the fragile health settings, WHO also goes to the service delivery level. So for those countries, there may be some possibility of funding to the extent below extent. But for the countries like Nepal, WHO provide the guidance. They provide the technical assistance for this one. But don't provide the hardware, some kind of software, don't purchase the softwares, but they provide the technical guidance, and also they can provide the experts if we need for Nepal to establish the telemedicine system. So this kind of soft programs can be supported by WHO, but don't expect much for the low stakes too much. Thank you.
Thank you, Pawan.
दाइको सुरुको इन्सुरेन्सको कुरा गर्दाखेरि मैले मेरो प्रेजेन्टेसनमा राखेको थिएँ, दाइले देख्नुभयो होला। टेलिमेडिसिन अथवा हाम्रो टेलिकन्सल्टेसनलाई चाहिँ जबसम्म इन्सुरेन्स प्रोग्राममा ल्याउँदैनौँ त्यसलाई हामी नेपाल सरकारले तिर्न सक्ने हैसियत राख्दैन अहिलेको लागि चाहिँ। त्यसमा हुनुपर्छ, त्यसमा हामी काम गर्दैछौँ एज अ बोर्ड मेम्बर अफ हेल्थ इन्सुरेन्स बोर्ड। हामी चाँडै नै त्यसको सल्युसनमा चाहिँ आउँछौँ। र यसमा समस्या कहाँनिर भन्ने कुरा छ, गभर्मेन्टले सबै अस्पतालहरूमा इलेक्ट्रोनिक मेडिकल रेकर्ड सिस्टम लाने भन्ने कुरा छ। केही हदसम्म केही पाटोमा चाहिँ दाइले नाम लिएका सबै संस्थाहरू, सबै अस्पतालले कुनै कुनै किसिमले त्यो सल्युसन अथवा एप्लिकेसन राखेका छन्, गरेका छन्। त्यसमा एउटा ठुलो च्यालेन्ज भनेको इन्टरअपरेबिलिटी नै हो। त्यो ठुलो च्यालेन्ज छ। इन्टरअपरेबिलिटी ल्याब हामी कहाँ जिआइजेडले मिनिस्ट्रीमा इस्टाब्लिस गरिदिँदैछ, उसको सपोर्टमा आउँदैछ। त्यसलाई फङ्सनल कतिसम्म बनाउन सकिएला अर्को च्यालेन्ज त छँदैछ। तर सुरुवात चाहिँ भएको छ। इन्टरअपरेबिलिटी ल्याब चाहिँ जिआइजेडको सपोर्टमा, जर्मन गभर्मेन्टको सपोर्टमा चाहिँ मिनिस्ट्रीमा ह्यान्डओभर हुँदैछ। एउटा इन्फर्मेसन सेयर गर्नु खोजेको मैले। र त्यो सँगसँगै एपिआई मार्फत चाहिँ इन्सुरेन्स प्रोग्रामहरू चलिरहेछन् अहिलेसम्म। र यो ल्यायौँ भने सबभन्दा पहिले हामीले गर्न बाँकी अरू पनि काम छ। कस्टीको काम हामी सायद सकाउनु पर्ला, टेलिमेडिसिनबाट दिने सर्भिसहरूको लिस्टिङ हामी सकाउनु पर्ला, नभए चाहिँ इन्सुरेन्सले कभर गर्ने के भन्ने कुरा गर्दाखेरि हामीसँग अहिले भएका थुप्रै सर्भिसहरूलाई त एकैचोटि इन्कर्पोरेट गर्न नसक्ला, राज्यले धान्न नसक्ला। त्यो धान्ने किसिमले हामी कुरा गर्छौँ। इनिसिएट चाहिँ यो वर्ष चाहिँ हुन्छ। हस्,
Thank you. Here is Dr. Rana Bogatif. He's from Rolpa Hospital. When Dr. Madan is here, so maybe you want to share something.
धेरै कुरा त नमस्कार सर, धेरै कुरा त अब मैले हिजै पनि भनेको थिएँ। एउटा इन्टेन्सन टेलिमेडिसिनलाई कसरी स्टार्ट गर्न सकिन्छ, नेपालमा कहाँ कसरी गरेको छ एउटा एक्सपिरियन्स लर्निङको लागि, र आफ्नो ठाउँमा चाहिँ त्यसको सुरुवात गरौँ भन्ने एउटा ध्येयका साथ आएको हो। अब धेरै कुराहरू त हजुरहरूबाट सिक्ने मौका पनि पायौँ, र अब यो जुन सुरुवात गर्न चाहेको एउटा इन्टेन्सन छ त्यसलाई चाहिँ एउटा मूर्त रूप दिनलाई हजुरहरूको सहयोग चाहिँ एकदम चाहिन्छ। र हामी जस्तो दूरदराजमा काम गरिरहेको चिकित्सकलाई यो एउटा बुनको काम गर्न सक्छ। त्यसैले हामी दूरदराजमा बस्ने भनौँ न अलि फार अफ डिस्ट्रिक्टबाट चाहिँ स्टार्ट गरिदिनु होला। यदि गभर्मेन्टबाटै यो कुराहरूलाई चाहिँ लागू गर्ने होइन, अब बजेटिङदेखि लिएर अन्य ल मेकिङ, अब यसलाई पनि हेल्थ सर्भिसको एउटा पाटो नै बनाउने हो भनेपछि हामीबाट चाहिँ गरिदिँदाखेरि यो अझ सहज हुने थियो, हामीलाई सहज हुने थियो त्यहाँ काम गर्नमा भनेर चाहिँ चाहन्छु।
Thank you. Dr. Dheeraj from Baitadi Hospital.
Thank you. Good afternoon, everyone. I am working at District Hospital Battery. I'm a MDGP. And as I mentioned yesterday and today as well, we are facing different problems. We are mainly having problem with referral of patients to the centers, to tertiary centers, because it took at least 8 hours to send the patients to Dhangari. So if we will be privileged with this telemedicine center, at least one hub center in the Sudur Paschim province, then it will be very kind to the population over there. So that's my request. Thank you.
Thank you. Dr. Raju from Spinal Injury Center.
Yeah, actually, our tele-rehabilitation system in our hospital is a bit different because the tele-rehabilitation, there are so many telemedicine, but tele-rehabilitation still I didn't see the listed even here in anyone's presentation. But Uday sir has mentioned rehabilitations while giving that to the Ministry of Health and Population. So we basically, this is very important for the people with disability and people who cannot reach to the hospital. And we have started tele-rehabilitation system from our center to the patient's home. You know, they even it is very difficult to travel those people from their place to even the hospital. So we have provided that service at home. So now I can the same thing I like to request, like Dr. Subhas, like it should be the tele-rehabilitation services should be in the insurance system. Then only we can grow this tele-rehabilitation system or telemedicine system in country. Thank you.
Thank you. Dr. Bijendra Joshi is Medical Director at Kathmandu Model Hospital.
Thank you, Dr. Uday, for your kindness. From yesterday's and today's meeting, we have learned a lot. And today we are very fortunate that Dr. Moran has given his precious presence among us. We have seen many improvement in these days in field of telemedicine. While I was also working through this since 2008 with Sarojit Talsar. And what we feel is everybody is trying, everybody is doing, but we are lacking some coordination. And now the time has came that we integrate all these things. Some are trying their best, some are regulating, some are seeing many hopes in future, and even already told in his slide that ministry has a plan, and just need is the integration of all these things, and we can look forward for a bright future of telemedicine in Nepal. Thank you.
Thank you, Dr. Bijendra. Here is Dr. Arun Neopane. He is one of the important person during CCMC. We all know Arun, sir. Please, sir.
Thank you. मैले भन्नुपर्दा चाहिँ बेसिकली जुन मदन डाक्टर साहबले इनेबलर्स भनेर दिनुभएको थियो अघि, मैले हेर्दाखेरि अल द इनेबलर्स आर इन प्लेस जस्तो लाग्छ हैन. एन्ड स्पेशली मैले यो 2 दिन एटेन्ड गरेँ बिकज आई एम फ्री दिस डेज, एन्ड आई फाउन्ड द्याट द निड इज देयर, द एन्थुजियाजम इज देयर, द सपोर्ट इज देयर. सो यु आर नट अलोन. त्यो 2 जना मान्छेलाई चाहिँ 2000 बनाइदिनुस् हैन. यु कल एनीवन फ्रम दिस, डाक्टर साहब इज देयर, एभ्रीबडी इज देयर. There are a lot of young guys who want to do something in life. Keep a name, nation को सर्भ गर्ने छन् के, टिम छ के तपाईको पछाडी, तपाई फुल पावरले अगाडि जानुस् न. There are so many people to help you. That's what I felt है मैले. तर you have to look back and ask for help है हैन. बिकज अब कसरी थाहा पाउँछन् र अरूले नभए हैन. आफ्नो आफ्नो काम सबैले गरिरहेछन्. यसो एकचोटी पछाडी फर्क्यो भने तपाईको 10 जना मान्छे आइपुग्छ मलाई लाग्छ है. Seeing the enthusiasm and the thank you very much.
Thank you, sir. Here is Dr. Sailendra from Armed Police Officer, Police Hospital. He has been working in telemedicine for years.
Yesterday and today, all the sessions were quite interesting, and everything has been covered. Everybody are working in piecemeal. These all work should be integrated, and there should be an umbrella, what I think personally. So all these, whatever ahead, a policy or something like that, umbrella should be there, and it should incorporate government as well as private, all the organization. That's all.
Thank you. Here is Kavin from Ask Foundation.
Hello, everyone. It was wonderful session from yesterday. And I would like to suggest, like, it's just a recommendation, if we have some foundation or like a legal foundation framework for implementing any telemedicine or digital health. So all the stakeholder, either private or public stakeholder, can work a lot. So there is still like a dispute, and there is still like confusion among us, like how to move ahead, like because there is no clear-cut guideline. So if we can work together and form a consortium on this, so we can give a proper direction for among us ourselves. Thank you.
Thank you. Here is Dr. Rajkumar from Dhulikhel Hospital.
नमस्कार सर म हिजो प्रेजेन्ट गरिरहेको थिएँ रुरल हेल्थ केयरको बारेमा त्यसमा मैले पर्सनली गएको केही हप्तामा चाहिँ जुन जिल्लाका साथीहरूलाई फोन गरेर सोद्धाखेरि धेरै ठाउँमा चाहिँ टेलिमेडिसिन भनेको सेटअप नै छैन भने कति ठाउँमा पहिला फङ्सनल थियो कोभिड अगाडि त्यसपछि त्यो केही कोभिडको टाइममा चाहिँ अर्कै कामको लागि युटिलाइज भयो त्यसपछि ब्याक टु द सेम सेटअप छैन अनि त्यो फेसिलिटी धेरै ठाउँमा हराइसकेको छ सो आई थिङ्क अब रुरल हेल्थ केयरलाई हामी प्रायोरिटाइज गरेर चाहिँ एक्सेस हेल्थ केयरको एक्सेस चाहिँ टाढासम्म पुऱ्याउँछौँ स्पेसली केयर पनि प्राइमेरी हेल्थ केयरलाई फोकसमा राखेर भन्छौँ भने जिल्ला अस्पताल अनि त्योभन्दा मुनि लेभलको जुन रुरल हेल्थ केयरमा प्राइमेरी केयरमा जुन पार्टिसिपेट गर्छन् त्यो सेटअपहरूलाई चाहिँ पक्कै नै इम्पावर गर्नुपर्छ होला र आई रिक्वेस्ट टु मेक सम रेगुलेसन एक्ट अर फेसिलिटी बजेटिङ एभ्रिथिङ फर रुरल हेल्थ केयर थ्याङ्क यू
Thank you. Yesterday's theme was the role of nurses in telemedicine, and Karkasi is running home-based care, nursing care, so she will speak.
Thank you, sir. Namaste, sir. लगभग प्राय सबै कुरा नै आइसकेको छ यसमा चाहिँ अब यो जुन हिजो र आजको जुन सिम्पोजियम ले चाहिँ यो वर्कसपले चाहिँ नि जुन एउटा ट्र्याकमा लानुपर्ने हो त्यो कुरालाई चाहिँ नि सबै साइडबाट सपोर्टिभ हिसाबले नै अगाडि बढ्छ भन्ने अपेक्षा राखेको छु थ्याङ्क यू
Thank you. Here is Dr. Sushil Koirala. He is also very much enthusiastic in digital health.
Thank you, Dr. Uday. Namaste, everyone. I couldn't attend yesterday, but I really feel full of enthusiasm after attending today's conference. Let's check this momentum, and in the coming fiscal year budget, I would like to ask Ministry of Health and Population to put in the President's speech. राष्ट्रिय कार्यक्रममा राष्ट्रिय नीति तथा कार्यक्रममा चाहिँ टेलिमेडिसिन चाहिँ हाम्रो टेलिहेल्थ चाहिँ एउटा प्रायोरिटी रूपमा आओस्. दिस इज आवर फर्स्ट निड. र अघि भने जस्तै एसओपीज र लेजिस्लेसनमा चाहिँ अब जहिले पनि कहिले के हुन्छ नि कहिले कानुन पहिला आउँछ चिज पछि आउँछ कहिले पहिला टेक्नोलोजी आउँछ अनि कानुन बनाउँदै जाने हो. लेट्स क्याच इट अप. र यो जुन सिम्पोसियम बनेको छ यसले गर्दा जुन ड्राइभ यो कोठामा मैले जुन इन्थुजियाजम भाइब्स फिल गरेको छु यो एनर्जीलाई किप गर्दै वी आर अल विथ मदन सर एन्ड टिम. लेट्स मेक इट ह्यापन है. थ्याङ्क यू.
Thank you. Here is Srisi.
Thank you, sir. मेरो क्वेसन चाहिँ अलमोस्ट कविनले लाइक करेक्ट आदि त सोधिसक्नुभयो. थ्याङ्क यू कविन क्वेसन सोधिसक्नु भएकोमा. मेरो क्वेसन चाहिँ सबै WHO हस्पिटल गभर्मेन्ट सबैलाई छ कि लाइक कति धेरै एप्लिकेसनहरू बनाएको छ रिसर्च पर्पजेसको लागि बनाएको छ. हिजोको प्रेजेन्टेसनमा आजको प्रेजेन्टेसनमा पनि देख्यौँ कति धेरै मेडिसिनको एप्लिकेसन EHR MHR यति धेरै बनाएको छ होइन सर. अनि एकरूपता छैन सबैले डुप्लिकेसन गर्यो भन्ने कुरा आइरहेछ होइन. एन्ड वी डोन्ट नो वेयर टु गो वेयर टु सिक ताकि एकरूपता आओस् अनि हामीसँगबाट कलेक्टेड इन्फर्मेसन पनि एउटै ठाउँमा बसोस् सो डुप्लिकेसन नहोस् इन्फर्मेसन पनि लस्ट नहोस्. अनि त्यसको लागि चाहिँ के गरौँ भन्ने चाहिँ मेरो सजेसन हो सर. थ्याङ्क यू.
Yes, thank you. Here is our Vice Chairman, Pawan Sakesha. He will.
Thank you, sir. I would like to repeat my question. So when you think of telemedicine, isn't it the appropriate time that we think of digital health rather than just telemedicine? Because when you think of digital health, we can encompass lots of things like M-health, E-health, whatever health we talk about. And when we think of digital health, there are three main important steps that we have to consider. One is digitization of medical. so that we can gather data out of it. So when we have data, we call it health informatics. So when we combine the equipment and the health informatics, it becomes knowledge repository system for us. And when we think of implementing the digital health system, I think it's high time we should start from the health post, not from the ministry or, not from the municipal hospital. So that like, let me give an example, if time permits. Sir. Okay. So we've been working in Dullu municipality, and recently we visited one of the remote health posts. It's in ward number 18. From there, it's almost 5 hours walk to the Dullu municipality hospital. Then we came across paramedics who knows how to run ultrasound machine. But because of the policy and guidelines, he's not able to check the patient by using ultrasound machine. Okay, so when we think of the digitization of ultrasound machines, he can at least check the patient, and the file can be sent to the doctor in Dullu Municipality Hospital. Okay, so that's one of the examples how we can make the digital health initiative effective and efficient. Thank you, sir.
Thank you. Here is Dr. Pooja Lamas. He is Information Communication Officer and Public Health Specialist working in Public Health Concern Trust.
Thank you, sir. I don't have a question, actually. I have an answer. धेरै इन्स्टिट्युसन्सहरूबाट चाहिँ इन्स्टिट्युसनलाइज गर्नु पर्यो डिजिटल हेल्थलाई टेलिमेडिसिनलाई भन्ने कुरा हिजो त आएको ठिकै थियो आज पनि आइरह्यो र सफ्टवेयर रेगुलेसन सिस्टम सो आई वुड लाइक टु वेलकम यु अल टु टेलिमेडिसिन सोसाइटी अफ नेपाल हामी एकचोटि नभएर हामी चाहिँ नि तपाईहरु सबैलाई समेटेर बारम्बार घचघच्याउने काम डेफिनेटली गर्छ सो जस्ट जोइन अस इन आवर फोर्स थ्यांक यू भेरी मच
Thank you. Thank you. She is also our treasurer, so she is asking you to join. So I think Dr. Madan will conclude and we'll have the closing.
Thank you. Thank you, Dr. Uday, and thank you all. एकदम ऊर्जा मिलेछ आज अरुण दाइले एकदम सही भन्नुभयो एकजना ले धेरै गर्न सक्छन् त्यो एकजना अगाडि देखिने मात्रै हो पछाडी ठुलो वर्कफोर्स हुन्छ मैले अघि हेल्थ वर्कफोर्सको कुरा गरे एकजना टेक्निकल मान्छे हुनुहुन्छ र त्योभन्दा अगाडि प्रेजेन्टेसनमा पनि हामी दुईटाको भाषा मिल्दैन भनेको थिएँ नेपाली बोल्नुहुन्छ दुईजना हामी नेपाली बोल्छौँ अब यो मैले खासै फेरि व्याख्या गर्नु परेन यहाँ सबैजनाको कुरा सुन्दाखेरि हामी सबैले नेपालमा भएको टेलिमेडिसिन प्रविधिलाई सरकारले अपनत्व लिदियोस् र ती दूर दराजमा भएका जसलाई सेवा चाहिने हो उनलाई सेवा दिन सकियोस् भन्ने चाहना हो त्यो हाम्रो दुर्गमबाट आउनुभएको डाक्टर साहबको होस् तथा हामी यहाँ सुगममा बसिरहेर सेवा दिने हामी व्यक्तिको जसको भए पनि त्यही चाहना हो यसमा यो 2 दिनको सिम्पोजियम वर्कसप र यहाँहरूको विचारले पक्कै पनि मन्त्रालय र म व्यक्तिगत मलाई पनि एकदमै ऊर्जा र बल मिलेको छ आगामी दिनमा हामी सँगै नै काम गर्छौं म यही फ्लोरबाट यहाँहरूलाई पनि आह्वान गर्छु हामी सँगै मिलेर अगाडि जाउँ र यसमा पक्कै पनि यहाँहरूको साथ रहनेछ मैले उहाँको एउटा कुरामा के भन्ने भने सटिक ठाउँ भेटिएन धेरै किसिमको एप्लिकेसन भयो कसले कसलाई दर्ता गर्ने अथवा कसले कसलाई चलाउने भन्ने कुरामा तर दुर्भाग्य स्वास्थ्य मन्त्रालयलाई त्यो बजेट छुट्याइएको छैन खासै त्यसले गर्दा अब टेलिहेल्थको बजेट उता भयो भने त्यसलाई कसरी गर्न सकिएला हैन त्यो एउटा समस्या हाम्रो बुझाइमा छ त्यसले मैले अघि नै टेक्नोक्र्याटलाई अवेरनेस एडभोकेसी भनेको थिएँ त्यो यस्तै कुराले गर्दा भन्या हो यी शब्दहरू अलि मेरा लागि चाहिँ घातक होलान् तर ती पिपुलको लागि चाहिँ एकदम सार्थक होस् भन्ने चाहना हो किनभने हामीले सरकारलाई जगाउनु पर्यो हामी सबै सरकार हौं एक किसिमको र हामी सबैले आफ्नो जिम्मेवारी निर्वाह गरेका छौं त्यसलाई जगाउन सकियोस् भन्ने नै चाहना हो र यो 2 दिनको सिम्पोजियमको जे जस्तो निचोड निष्कर्ष आयो त्यो निष्कर्षले सायद हामीलाई टेलिमेडिसिन अब पनि गरेनौं भने सायद ढिलो हुन्छ कि भन्ने चाहिँ हामी सबैले बुझ्न सक्यौं भने त्यही नै ठुलो हो र हामी सबै जिम्मेवारीमा यो रोटेसन हो हैन यो म्युजिकल चेयर हो हाम्रो चाहिँ हैन तर एज अ पब्लिक जहिलेसम्म हुन्छौं त्यो सधैँ त्यही बेसमा सेवाग्राही सेवा प्रदायक दुईटै रूपमा हामी बस्छौं त्यहाँ चाहिँ पक्कै पनि हामीले एडभोकेसी राम्ररी गर्न पर्छ र आगामी दिनमा हामी सँगै जान सकौं सबैको विचार लिएर अगाडि बढ्न सकौं र यहाँहरुको साथ सहयोग भयो भने स्वास्थ्य मन्त्रालयले अबको नीतिगत रूपमा कतिपय कुरा गर्नुपर्ने छ भने कतिपय कुराहरू व्यवहारिक प्रस्ट्याइहरू पनि चाहिन्छ त्यो प्रस्ट्याएर अगाडि बढ्न सकौं भन्ने नै चाहना सहित यहाँहरुको उपस्थिति र यो सिम्पोजियम वर्कसपमा डाक्टर उदय लगायतको टिमले जुन यो अवसर दिनुभयो म उहाँलाई पनि धेरै धेरै धन्यवाद दिन चाहन्छु एकदम आभारी छु र यहाँहरुको विचारले सारै प्रेरणा मिलेको छ आगामी दिनमा सँगै काम गर्न सकियोस् यही मेरो चाहना छ धन्यवाद
हस् थ्यांक यू अघि म्युजिकल चेयर भनिहाल्नुभयो साँच्चीकै मिनिस्ट्रीमा र यो डिभिजनल हेल्थमा म्युजिकल चेयर नै आज एकजना भेट्न गयो 6 महिनापछि अर्कै लिड हुन्छ हैन 1 वर्षपछि अर्कै लिड र हामी सबैको चाहना चाहिँ डाक्टर मदन बिकज हि इज यङ एन्ड हि इज अब मैले त भनिसकेँ भविष्यको सचिव नै अब भनेदेखि जहाँ गए पनि हि सुड लिड एटलिस्ट त्यहाँ घचघच्याइराख्ने काम चाहिँ एटलिस्ट डाक्टर मदनबाट होस् हाम्रो त्यही चाहना हो हस् थ्यांक यू Thank you very much. Thank you, sir.